Hello everyone and welcome to my channel. This is Asif Qureshi and you are watching Dr. Asif Lectures. Today we are going to discuss about parathyroid glands and calcium regulation. At the top of the picture here you see a thyroid gland, lateral view of a thyroid gland, and you see on the posterior surface there are two black bodies. These are the parathyroid glands. So parathyroid glands are present on the posterior surface of thyroid glands. They are usually 4 in number, 2 superior parathyroids and 2 inferior parathyroids, okay? The blood supply to parathyroid glands, the arterial supply is via superior and inferior thyroid artery, and the venous drainage is to the superior, middle and inferior thyroid arteries, while the lymphatic drainage is to the deep cervical and paratracheal lymph nodes, and the nervous supply is via the sympathetic ganglia, superior and middle. So these anatomical bits you need to remember because sometimes they ask these straight questions in the exams, okay? Now on this image you see 3 different organs. On the left side is the pharynx during development. So this diagram is basically talking about the embryological development of parathyroid glands. So embryologically the parathyroid glands are developed from the endodermal lining of 3rd and 4th pharyngeal pouches. So you see here, this is the pharyngeal tube, and from the 3rd pharyngeal pouch develops the inferior parathyroid, from the 4th pharyngeal pouch develops the superior parathyroid, okay? You need to remember these because they sometimes ask this in the examination. Also, you have to remember that the inferior parathyroids sometimes migrate even inferiorly and they are present in relation to the thymus. So when there is an operating surgeon, he or she should be aware of the fact that parathyroid glands are usually, the inferior ones, are usually present on the inferior border of the thyroid, but they may also descend down up till thymus, okay? So these important embryological and anatomical bits I hope are all very clear to you because in exams you commonly find questions related to this diagram, okay? Remember, 3rd pharyngeal pouch, inferior parathyroid, 4th pharyngeal pouch, superior parathyroids, okay? Total 4 in number, and these 4 parathyroids, they are composed of different types of cells. The main type of cell which produces the key regulatory hormone is the chief cell. There are also other types of cells, but you have to remember chief cells present in the parathyroid gland, and the chief cell produce a hormone which is called parathyroid hormone. The parathyroid hormone, also designated as PTH here, then acts on 3 different organ systems. You know what are those organ systems? They are bone, kidneys and gut. Parathyroid hormone is released from parathyroid gland. Parathyroid hormone acts on 3 organ systems which are bone, kidneys and gut. Actually on the gut, it acts via vitamin D, so it does not have direct receptors there. Direct receptors for PTH are present on bones and kidneys, okay? So remember these. So I'm trying to build up a basic understanding that from where the parathyroid hormone is released, where does it act, so you should have this comprehension before we dive deeper into the physiology, pathology and medicine related to the parathyroid gland. This diagram is again telling you that 3 organ systems are targets for parathyroid hormone, but you also need to remember that along with parathyroid, vitamin D and calcitonin also play a role in regulation of calcium metabolism, okay? So calcium is regulated basically by 3 hormones and 3 organ systems. 3 hormones and 3 organ systems, easy to remember, okay? The 3 hormones are parathyroid hormone, vitamin D and calcitonin. And the 3 organ systems you already know, bone, kidneys and gut. Now, also, I must mention here that amongst the 3 hormones, the parathyroid hormone, PTH, vitamin D and calcitonin, major player in calcium metabolism is PTH, parathyroid hormone, okay? Remember this. And this obviously is the circulation because parathyroid hormone comes into circulation and reaches to different target organs. Now, next I'm going to show you some numbers which you don't actually have to remember for your boards, but this is just to give you an idea. These numbers show calcium concentration and exchange in the body. These are representative in millimoles per liter. So for example, it's telling you that we take via diet around 25 millimoles per liter calcium per day. We excrete around 20. and you see different numbers showing how calcium is moving to circulation, from kidney, from bones to bones. And you should also notice that bones have the highest concentration of calcium. You see, 30K, which means 30,000 millimoles per liter of calcium is present within the bone, and therefore no wonder we call bones as the calcium bank of your body. Okay, so this diagram tells you that there are 3 hormones important for calcium metabolism, 3 organ systems which are important for calcium metabolism, and that bones are the calcium banks. Okay, let's move forward. Wow, I love this image. There's a chief cell, and on the chief cell is a receptor, red in color. That receptor is called calcium sensing receptor. Now, when we say calcium sensing receptor, it by definition tells you what's the job of this receptor. It senses calcium. So whenever the calcium concentration in the blood is low, it feels it. Whenever the calcium concentration in the blood is high, it feels it. So this is a calcium sensing receptor, which is able to sense the levels of calcium in the blood. Okay? And if the calcium levels are low, listen carefully, if the calcium levels are low, it releases a lot of PTH. If the calcium levels are low, it releases a lot of PTH. And then this PTH goes to different organs, and you know those organs are bone, tell me the other one, kidneys, and gut. Okay, remember this. Before proceeding forward, I should also tell you that, so let me ask you, when is PTH released? When there is low calcium or high calcium? Low calcium. Low calcium in the blood, PTH is released, okay? Along with low calcium, high phosphate and low vitamin D are also signals for release of PTH, but major release factor for PTH is low calcium levels, okay? Remember this point. Now, once the PTH is released, this PTH goes onto bone. And the cells of the bone which have the receptor for PTH are the osteoblasts. So once the PTH fits here on its receptor, it releases cyclic AMP through, the G-coupled protein and adenylate cyclase pathway. Cyclic AMP is released, and then this osteoblast releases a factor which is called rank ligand, which has the receptor on osteoclast, and now osteoclast is activated, another cell type in the bone, and this osteoclast sits on the bone and try to chops off the bone, try to dissolve the bone. And once the bone is dissolved, it releases a lot of calcium, it releases a lot of phosphate, and it also releases a lot of hydroxyproline, because the formation of the bone, if you study the histology of the bone, it is composed of calcium, phosphate, and also hydroxyprolines. So when you chop off the bone, all the products will be released into the blood. So here is the summary one more time. There is low calcium in your blood. It is sensed by the chief cells. Chief cells produces a lot of parathyroid hormone, and the parathyroid hormone will go on to 3 organ systems. The first one we are discussing is the bone. So what are the cells where parathyroid hormone goes and starts the action? Osteoblast. Osteoblast produces a lot of cyclic AMP and releases rank ligand and other mediators, and then rank ligand goes on to activating osteoclast, and once the osteoclasts are activated, they go and sit down on the bones and say, hey bones, here I am, I'm going to chop you off, I'm a cutter, I'm a bone cutter, osteoclast, cutter. So they start cutting the bone. And whenever they start cutting the bone, what is released in the blood? Calcium, phosphate, and hydroxyproline. So remember this, calcium, phosphate, and hydroxyproline are increased into blood circulation, released into blood circulation as a result of PTH. Is this very much clear to all of you? I hope so. What is the next organ where PTH actually performs the action? The next organ was kidneys. So here is a nephron in front of you. In the nephron, there are different parts, and now we will be discussing that where exactly PTH goes and performs its function. Okay? Look, the early part of the nephron is the proximal convoluted tubule. So this yellow cell here is the PCT, the proximal convoluted tubule. See here, the proximal convoluted tubule also has PTH receptor. So what happens is that PTH reaches to the proximal convoluted tubule, sits down on the receptor, activates the G-coupled protein and adenylate cyclase, and ultimately also here a lot of cyclic AMP is produced. So as a result of PTH action, cyclic AMP is produced, and this cyclic AMP will obviously be released into the urine. So if you have a lot of cyclic AMP in the urine, it is a marker of high PTH activity, okay? So PTH will go onto the proximal convoluted tubule cells, activate the receptor, and then what happens is very important. Now, one important point before I show you the next image is when PTH acts on bone, what were released into blood? High calcium, high phosphate, because bone is composed of calcium and phosphate and hydroxyproline. So when osteoclast cuts the bone, calcium is released, phosphate is released, and hydroxyproline is released. And all of them, they go in circulation. And what happens next? They go into kidney, they get filtered there, and they go down in the lumen. So in the lumen, there will be a lot of calcium, there will be a lot of phosphate, and there will be a lot of hydroxyproline. And one more thing I told you, there will be a lot of cyclic AMP. So a lot of calcium, a lot of phosphate, and a lot of hydroxyproline and cyclic AMP now are present into the nephron lumen, okay? Usually, in the proximal convoluted cell, there is a receptor. There is a receptor for absorption of phosphate. So usually phosphate is absorbed in the proximal convoluted tubule, but you see here, action of PTH negatively inhibits this receptor. So if this receptor is negatively inhibited, phosphate will not be reabsorbed. And when phosphate will not be reabsorbed, it will be released out in the urine. So you see this effect. Now, let me repeat again. This is getting a lot of information. So let's begin from the very beginning. What happens? What happens, guys? Let's go to the back. This is it. When there is low calcium levels, there is high PTH release from the chief cells. This PTH goes on to activating osteoblast, produces a lot of cyclic AMP. From the osteoblast, rank ligand is produced, goes and activates osteoclast, and now osteoclast act on bones and releases a lot of calcium, a lot of phosphate and hydroxyproline. Now this calcium, phosphate and hydroxyproline will go into the nephron, and they will be in the nephron, okay, which is the next target organ for PTH action. And where does PTH act? Proximal convoluted tubule, which has a receptor. And activation via PTH blocks the phosphate reabsorbing receptor. So as a result, phosphate will not be reabsorbed. And once phosphate is not being reabsorbed, who blocked it? PTH. PTH blocked the absorption of phosphate. Now this phosphate will obviously go into urine. Getting my point? Good. What PTH also does here in the proximal convoluted tubule is a very important thing, that it increases vitamin D activation. You know, this is a normal function of proximal convoluted tubule, that one hydroxylation happens here, so vitamin D activation actually happens here, and vitamin D activation happens in the proximal convoluted tubule, and as a result, more and more vitamin D is activated. Now, as a result of more and more vitamin D activation, you know what is the job of vitamin D? It goes to the gut. It goes to the gut and asks the gut to absorb more and more calcium and phosphate. So the overall effect of vitamin D activation is further increase in calcium levels and further increase in phosphate levels, okay? So this will happen. By the way, in the urinary outflow, I've also mentioned that cyclic AMP will be released and hydroxyproline will be released. I told you hydroxyproline is coming from the bones and cyclic AMP is coming from overactivity in the proximal convoluted tubule. Overactivity of what? Overactivity of parathyroid hormone, okay? So up till now, this should all make sense to you. Let me repeat one more time. Low calcium levels, high PTH from chief cells, PTH goes to osteoblast. Osteoblast releases rank ligand, it goes to osteoclast, and osteoclasts start cutting the bone, releases a lot of calcium, phosphate, and hydroxyproline. All of them go to the nephron, and in the nephron, usually phosphate is reabsorbed, but now PTH will stop the reabsorption. As a result, this phosphate will go and pee out in the urine, okay, along with cyclic AMP and hydroxyproline. Another function of PTH on proximal convoluted tubule is activation of vitamin D. Vitamin D in turn goes to the gut and asks the gut to absorb more calcium and more phosphate, okay? So this is why I told you that parathyroid hormone has direct receptors on bone and nephron, but on the gut, its action are via vitamin D. I hope this makes sense to you now. So up till now, what has happened? We are trying to get rid of the phosphate in the urine, and we are trying to increase the amount of calcium in the blood by a cutting of bone, as well as increasing in the number of vitamin D activation steps. So vitamin D is being activated more, gut is absorbing more and more calcium. So overall effect up till now is increasing calcium concentration and throwing out phosphate, okay? And this is also very easy to remember because parathyroid hormone is a phosphate throwing or phosphate trashing hormone. So it trashes phosphate in the urine, okay? Now on the nephron, there is another cell which are called the distal convoluted tubular cells. Parathyroid has also receptor on the distal convoluted tubule. Now the distal convoluted tubules, look, their story is very interesting. What happens there? What is the action of parathyroid on distal convoluted tubule? Usually in the distal convoluted tubule on the luminal side, there is a calcium receptor. And it just takes all, there's a calcium channel and it reabsorbs calcium. So whatever calcium comes in the nephron, the body reabsorbs it. And now once it reabsorbs, the concentration of calcium within the distal convoluted tubule becomes high, and now you need something to pump this calcium out in the blood, so that there is less concentration within the cell and more calcium can be reabsorbed from the urine, okay? So calcium is being reabsorbed into the distal convoluted tubule cell, and there are basolateral cells, the pumps basically, these pump calcium out of the cell into the blood, out of the cell into the blood. So as a result, what happens that calcium is not excreted in the urine, it is reabsorbed and thrown into blood, okay? Now what is the role of PTH here? Where does the PTH fix in here? PTH does this. Action of PTH increases the activity of calcium pumps. So more and more calcium is thrown into the blood and more gradient is produced so that calcium moves from the urine, from the lumen of the nephron into the cell. So the calcium reabsorption capacity is increased because parathyroid hormone increases the action of these calcium pumps, okay, via phosphorylation. Obviously, you remember that parathyroid works via cyclic AMP, and via cyclic AMP it produces protein kinase A, and protein kinase A increases the phosphorylation of these pumps, so these pumps become hyperactive. So whatever calcium comes inside the cell, they throw in the blood, comes inside the cell, throw in the blood. And by doing so, a big gradient is produced, so more calcium is reabsorbed from the urine. So this is what all are the consolidated actions of PTH. So this slides completely explains the physiology of how parathyroid hormone actually works. Remember, parathyroid works on bone, it works on kidney, and it works on gut via vitamin D, okay? Now you exactly know what is the first cell in the bone which is actually influenced is the osteoblast. The second cell is the osteoclast. An osteoclast cuts and releases a lot of calcium, phosphate, and hydroxyproline. And then in the kidney, what are the cells where PTH performs its action? Proximal convoluted and distal convoluted. In the proximal convoluted, it stops phosphate reabsorption. So it throws out more and more phosphate. In the proximal convoluted tubule also, it enhances vitamin D activation, okay? And in the distal convoluted tubule, it activates the calcium absorptive mechanisms. So what will be the overall effect? What will be the overall effect? The overall effect will be, the PTH action will be increase calcium and increase phosphate from the bone. Please tell me that you understand this, because if you don't understand, you need to rewind the video and see that previous slide again. The function of parathyroid is increasing calcium and increasing phosphate from the bone into the blood. And who is actually doing this? Osteoclast. And who is activating osteoclast? Rank ligand. From where is the rank ligand being released? Osteoblast. Who is directing osteoblast? PTH. So the action of PTH is increased calcium and increased phosphate from the bone. I hope this is very much clear. Increased calcium and increased phosphate from the gut by the action of vitamin D. And was vitamin D more activated? Yes. How? Because PTH acts on activation of vitamin D in the proximal convoluted tubule. Does that make sense to you? Link with the previous slide, okay? Increased calcium absorption from the distal convoluted tubule. So more and more calcium is reabsorbed from the distal convoluted tubule because it makes the channels, the pumps, activated. Remember that I told you? Decreased phosphate from the PCT, proximal convoluted. We discussed that in the proximal convoluted tubule, phosphate reabsorption is inhibited. So because it is inhibited, it is decreased in the reabsorption in the PCT. So more and more phosphate goes out in the urine, okay? And there is increased vitamin D activation in the PCT. So all these facts which are listed here should be very much clear in your head, because this is very important to understand these in order to understand the pathology and the medicine, okay? So I hope this is very clear to you. So the overall effect in the serum is increasing the level of calcium and decreasing the level of phosphate. Why is calcium increased? How is calcium increased? By the action of PTH on bones, by the action of PTH on vitamin D, and by the action of PTH on kidney, reabsorbing more calcium. So all these actions contributes towards increasing the concentration of calcium in the blood. And what happens to phosphate in the blood? Goes down. Phosphate levels goes down because it releases it from the bone, it gets it out from the gut, but then it throws out in the kidney. Yeah, you getting me? So on the bone, increased phosphate by the action of PTH. From the gut, increased phosphate by the action of vitamin D. But ultimately what happens to phosphate? It gets out in the urine because it cannot be reabsorbed back. Okay, so the overall action, you must remember what is the action of PTH. After all this discussion, that's the take-home message. Action of PTH, blood chemistry, increased calcium, decreased phosphate. What happens in the urine? Increased phosphate, you know, increased phosphate going out in the urine. Increased cyclic AMP, you know why? Because cyclic AMP is the second messenger system used by the parathyroid hormone. So more and more parathyroid action, more and more cyclic AMP production, okay? And that goes in the urine. And from where is the hydroxyproline coming out? Hydroxyproline is coming from bones, okay? So I hope this is very much clear to all of you now. This slide talks about different important chemistry values for your examination purpose. Now, usually in the exams, either this is MRCP exam or your undergraduate exam or STEPS, whatever you talk about, usually they give you the normal values, okay? But in order to save time, you know, you need to at least remember common values. Say, for example, value of sodium, potassium, calcium. These should be at the top of your head so that you can quickly go through the questions and answer them very, very quickly. Otherwise, you'll have to go to look for the normal values. If they are not given in the parentheses, you have to go to the tab and it may waste your time. So, I have given in this lecture a few important values. For example, the total plasma calcium. Now, one thing you need to remember that calcium in your body exists in different forms, and we will talk about it. It is bound to proteins, it is present as free ionic calcium, and there are some other forms. But what we measure in the laboratory is the total calcium, because calculating ionic calcium, the free calcium, is really a tough job. It's a short half-life and it's difficult chemistry. So whenever we talk about calcium levels, this is the total calcium levels, okay? And total normal calcium levels are somewhere between 2.2 to 2.6 millimoles. This is millimoles, okay? They may give in you examination the milligram per deciliter or some other unit. Whatever the unit is, you need to see the normal values in the same unit, okay? For calcium levels, there is also a correction formula available because calcium, when bound to albumin, there are conditions where albumin levels fluctuate. So if albumin levels are above or below 40 grams per liter, you have to correct the value of calcium accordingly. So for example, add or subtract 0.02 millimoles per liter for each gram up or down or up for albumin levels if they are disturbed from 40 grams. And so as an example, for example, if the albumin levels are 42 grams, okay, 42 grams per liter. So this is obviously different from 40 grams. So this is up above 40 grams, 2 point values up 40 grams. So what I will do is for 2 point values up, I will either add or subtract. You tell me, I'll subtract. I'll subtract the value of calcium. So you may want to remember this formula. They usually don't test you on this. They tell you the corrected value of calcium is this. So I'm discussing this just for your understanding that you have to either subtract or add 0.02 per point change in albumin levels if it is above or below 40 grams per liter, okay? Phosphate levels, this is also an important point that sometimes if you put tourniquet in to take blood out for phlebotomy, tourniquet usually disturbs and increases the calcium, which may be the false result. So if it's really critical to investigate the value of calcium, avoid using tourniquet, okay? That's an important tip. Phosphate levels are usually 0.8 to 1.4, again millimoles. Plasma parathyroid levels are 10 to 65 nanograms. They may be giving you in picograms, okay, which is a different value. Serum 25 hydroxy D3, which is the vitamin D3 levels. So you are called vitamin D deficient if your value is less than 25 nanomoles, and you are said insufficient vitamin D holder if this is between 25 to 75, okay? And 24-hour urinary calcium is also sometimes. So these are some important values. You may want to at least remember the calcium levels, okay? At least remember the numbers for calcium, 2.2 to 2.6 millimoles per liter, so that in the examination question, you read it and understand it quickly that they are talking about a condition which is hypercalcemic or a condition which is hypocalcemic, okay? Remember this value. I told you calcium exists in different forms, and those different forms are around 40% is bound to the protein. It's bound to the albumin, and then around 10% is bound to different anions, such as phosphate or something, as a complex. And then only 50%, half of your total calcium in the blood is ionized or free calcium. It is this calcium, the free calcium, which is main regulator of parathyroid hormone. So the calcium sensing receptors in the chief cells are actually influenced by this free calcium, okay? And the parathyroid PTH actually modulates this calcium, right? Now, also this is an important discussion for examination. Whenever there is alkalosis, there is increased calcium binding to the proteins. What does that mean? That means that the free calcium will be decreased. Now, this is you need to understand the concept. So, any condition which leads to alkalosis, okay? Alkalosis means that there is a higher pH, and in the blood, if alkalosis happens, your body will put all the efforts to bring the pH to normal, okay? And in order to do so, hydrogen ions, which are bound to proteins normally, they detaches themselves from the protein. And once they detach themselves from the protein, why are they being detached? The purpose is to contribute towards alleviating the condition of alkalosis. So whenever there is an alkalotic environment, it needs more and more hydrogen. So more and more hydrogen is detached from the protein to normalize the body pH. Now, when hydrogen is released from the protein, there are spaces now available for calcium to bind. So calcium now binds to the proteins. So whenever there is, so say for example, this is a protein and this is hydrogen. So whenever there is calcium coming in, it cannot bind the protein because there is already a hydrogen sitting down there. But in alkalosis, this hydrogen goes away. And once the hydrogen goes away, now this is free. The seat is free. And who sits now here? Calcium. Now calcium sits here. And because calcium sits here, free calcium level goes down because it's more and more binding to the protein. So the bottom line is this. In alkalosis, calcium binding to the proteins is increased, okay? Because hydrogen is detached from the proteins. And as a result, patient may feel, because the ionic calcium is now going down. Where is it going? It's going to the proteins. So iron, not calcium, free calcium is going down. And the patient may feel, start feeling pains or cramps, all the symptoms of hypocalcemia, okay? Now, whenever there is hypocalcemia, what will happen to your body? Which cells of your body will sense that calcium is going down? Chief cells. And what will they release? PTH. PTH. So you see all this, this is where they commonly routinely ask this, and they try to trick you that, well, there is a condition where they give you a whole vignette and they establish that there is alkalosis and what will happen to the parathyroid hormone. So you need to remember, whenever there is alkalosis, more calcium binds to protein, free ionic calcium goes down, hypocalcemia develops, and PTH is released, okay? The opposite actually happens, exact opposite happens when there is acidosis. When there is acidosis in the blood, hydrogen doesn't detach. And when hydrogen doesn't detach, calcium doesn't bind, sort of thing, okay? Now, other common causes of hypercalcemia, remember these two common causes of hypercalcemia. Hypercalcemia, one cause is hyperparathyroidism. The parathyroid gland have primary hyperparathyroidism. They are releasing a lot of parathyroid hormone. Now, this can be because of adenoma, this can be because of a cancer of parathyroid, but there is something wrong intrinsically within the parathyroid gland that they are producing a lot of PTH. And when a lot of PTH will be released, calcium levels will increase. So, high PTH will lead to hypercalcemia, okay? Other common causes are PTH, PR means parathyroid hormone related protein. This is usually produced from other cancers such as myeloma. So somewhere else in the body there is a cancer which is producing parathyroid hormone related protein, and that protein acts exactly like parathyroid does. Now this goes to the bones and increases the calcium level, so it also causes hypercalcemia. But remember, this is an important point here. How do you differentiate between the two? In the first, which is we call the primary hyperparathyroidism, levels of PTH will be higher. But if it is due to some other malignancy, levels of PTH will be low. Why? Because due to the malignant situation, parathyroid related hormone is producing a lot of hypercalcemia, and this hypercalcemia will actually inhibit parathyroid hormone release. So if parathyroid hormone is increased, primary hyperparathyroidism. If parathyroid hormone is decreased and calcium levels are still high, think about other malignancies, myeloma, okay? There are some other causes of hypercalcemia that you need to remember. If there is hypervitaminosis D condition, if the patient is, taking a lot of vitamin D, or if there are some conditions such as sarcoidosis, tuberculosis, these granulomatous diseases have intrinsic mechanism where activation of vitamin D happens a lot. It is hyperactive. So hydroxylation step, one hydroxylation is increased and a lot of vitamin D is produced. So in any condition, when a lot of vitamin D is produced, calcium levels will go up, okay? And you know how. There are some endocrine conditions, thyrotoxicosis and Addison disease. There are drugs also available. So you need to remember these causes of hypercalcemia. But let me tell you that the first two causes that I told you, primary hyperparathyroidism and other cancers such as myeloma, they are the most common, and together they contribute to more than 80% causes of hypercalcemia. So hypercalcemia is usually present by the first two causes, but you need to remember the other ones in case they ask you in the examination. Now what actually happens when there is hypercalcemia? Symptoms: if it is mild hypercalcemia, nothing happens. So if usually the calcium levels are less than 3 millimoles per liter, nothing happens. It's asymptomatic. And you incidentally finds it when you are doing some other chemistry reports and you find that, oh, well, there are some high levels, but patient is asymptomatic. You don't need to, the patient don't come to you with presenting complaints. But if they do come to you with presenting complaints, then usually the hypercalcemia is severe. And what are the symptoms? Let's have a look. Fatigue. Now, why fatigue? Because when there is a lot of calcium in the blood, what will happen? Calcium actually guards the sodium channels and the action potential is delayed when there is a lot of calcium. So when there is a lot of calcium, sodium entry is delayed, it's stopped, it's inhibited, therefore the action potential, generation of action potential is delayed, and therefore the patient feels lethargic and fatigued, okay? Bone pain, obviously you can imagine, when there is a lot of parathyroid around, such as in primary hyperparathyroidism, what will happen is that the bones will be being cut a lot by osteoclast, and patient feels bone pain. Okay, there's a lot of inflammation also, and nothing good is happening in the bone. The bone is being destroyed, so patient complains of bone pain, pathological fractures, a lot of, when you do a lot of demineralization in the bone, a lot of calcium is being released from the bone, a lot of phosphate. So basically you are destroying the infrastructure of the bone. Pathological fractures can happen. Polyuria. Why polyuria happens? Because if there is hypercalcemia, this increased level of calcium can go in the nephron and block the late parts of the tubular system. And once that is blocked, what is the job of the last part of the nephron? Last part of the nephron is basically reabsorbing a lot of water. So this action will be disturbed. When water reabsorption is disturbed, a lot of urine will be produced, water will be produced, excreted in the urine form, and that's why patient feels polyuria, and as a result, patient also feels a lot of thirst because he's losing a lot of water, okay? Increased thirst is one of the symptoms. Increased calcium. When there is high amount of calcium present, it can form stones. If the stones are produced in the kidney, patient will complain of the flank pain, okay? There may be peptic ulcers because calcium is a stimulator for increased gastrin release. So patient may present to you with peptic ulcer. And of course, when there is a lot of calcium available, it may deposit in different parts of your body, which is what we call metastatic calcification. Metastatic calcification. And obviously this is favored by the alkaline. I told you, when there is an alkaline environment, more calcium binding happens, okay? So the point I am describing all this is that each and every symptom presented here should make sense to you. If it does, it means you are following the lecture and you are understanding it absolutely correctly. If it doesn't, please review the video. Try to see what we discussed in the previous minutes, okay? So also these symptoms are important because usually in the examination, they start the question like this. So if they talk to you, there is a patient who is coming to you with complaints of constipation, lethargy, fatigue, flank pain, polyuria, polydipsia, you are thinking about hypercalcemia, okay? So these symptoms are the usually starting lines of a clinical question. They tell you there is a patient and these are the presenting complaints. And based on the presenting complaints, you should pick up what is the problem, okay? Oh, I love the question. There are questions, whenever there are questions, I love them because they try to joggle your head, you try to move your head around, and the knowledge you have attained so far, this is now the time to apply the knowledge, okay? Let's read the question together. There's a 65-year-old female presents to your clinic with depression, constipation, thirst, depression, constipation, thirst, depression, also because there are delayed action potentials, disturbs the neurological imbalance, and all these are already telling me there is something wrong with calcium metabolism, okay? Look at the labs, calcium 3.1 confirms it. Calcium levels are high, So there are symptoms of hypercalcemia, there is laboratory value of hypercalcemia, very high, okay? What is the next best test you would order to determine if this is really a hypercalcemia? And the options are ESR, parathyroid hormone, phosphate levels, and ACE levels. Now, this allows us to discuss a very important slide. Whenever a patient comes to you with hypercalcemia and symptoms of hypercalcemia, the next best test to do is PTH. I'll tell you why. Well, ESR is a very non-specific thing. It will tell you there is inflammation or any inflammatory condition can lead to increased ESR, chronic inflammation. Vitamin D levels are not going to tell you anything about why calcium is high. You will not be able to locate the cause. Phosphate levels and ACE levels, so, which are more important in granulomatous diseases. So, parathyroid hormone and why. Let's go through the diagnostic algorithm of diagnosing hypercalcemia. So whenever you have a patient, when you are suspecting hypercalcemia, so when you suspect hypercalcemia, that means you have a patient with thirst, bone pain, depression, constipation, polyuria, polydipsia. So when you suspect somebody, what you do next is order serum calcium levels, okay? And you order them with a couple of days gap, and you take multiple readings in the morning, fasting, and if that establishes that calcium levels are high, the next best thing is to do serum PTH. If serum PTH is high or detectable levels, you confirm the diagnosis of primary hyperparathyroidism. So it is important to take the PTH values, and if PTH is high and calcium is high, you are talking about primary hyperparathyroidism. But if PTH levels are low, now is the worry. If PTH levels are low, this means that this hypercalcemia is because of some other thing. And that some other thing can be a tumor, myeloma for example. So myeloma releases parathyroid hormone related protein. You remember that? Parathyroid hormone related peptide, which is the cause of hypercalcemia. So you need to figure that out. Then you need to do additional tests. So go back again. Whenever you have a patient with which you suspect is hypercalcemic patient, you order calcium levels. After the calcium levels, if they are high, you order PTH. If PTH is high, primary hyperparathyroidism confirmed. But if PTH is low, you need to do a lot of other tests. And those tests are, you have to do protein electrophoresis to exclude myeloma. You have to do serum TSH to exclude thyroid disorders. You need to do cortisol test for excluding Addison disease. I told you, thyrotoxicosis, thyroid problems, Addison disease, they are also causes of hypercalcemia, okay? And you need to do the ACE levels to rule out granulomatous disease, sarcoidosis. So now go back to the previous question. Now you read the question again, and this will be in context that after a patient who is presenting to you with complaints looking like hypercalcemia, and you do calcium levels, they are high, the next best test would be PTH, okay? I hope this all makes sense to you. Let us now discuss another question. A 72-year-old aged presents to you with fatigue, confusion, abdominal pain, and his calcium is 3.8. So all symptoms of hypercalcemia and then high calcium levels, okay? You give 3 liters of normal saline and pamidronate, which is a bisphosphonate, and then on the following day, the calcium levels are still elevated. What would you do next? Now, this question actually tries to, compel us to learn the management algorithm of hypercalcemia. And I can tell you the answer here is calcitonin, and we'll come back to the question once we have discussed this. Now, the first thing you need to remember is start the management if the calcium levels are above 3.5. You do not wait for lab values to come back. By the way, which lab would you send if calcium levels are high? PTH. So you don't have to wait for the result, you immediately start the management, okay? Because that may be a problem if you keep on waiting and do not start the management. So start management, and what is the management? Rehydrate the patient. Rehydrate the patient quite aggressively, 4 to 6 liters of normal saline on day 1, and then you reduce it down on the subsequent days. You start intravenous bisphosphonates, pamidronate is the first line, obviously, and you can give prednisolone, but prednisolone is effective only in either myeloma or granulomatous diseases, okay? You can also give calcitonin, which is very fast acting. So calcitonin is a good option because it initiates the action very fast. Now, oral phosphates can be given, but usually they are not major streamline in the management plan these days. Now go back to the question. Go back to the question again. Go back to the question again, okay? So they're telling you that there's a patient with hypercalcemia who presents to you. You started the management, you give the IV fluids, and you give one of the bisphosphonates, but calcium levels are not going down. What would you do next? A, will you give zoledronic acid? I would not, because zoledronic acid is another bisphosphonate, and once one of the bisphosphonates, which is the best first line, is not working, then zoledronic acid will not add any value to the management plan, okay? Gallium and pligamycin, they used to be used, but they are not used anymore in the management of hypercalcemia. Sinaxolid, this is something which inhibits the parathyroid and is not used for treating calcium levels, for example. Calcitonin will act quickly. So the best option in a patient who is not responding to bisphosphonates, jump onto calcitonin, and that usually gives a very rapid response, okay? So remember this management plan for hypercalcemic patients. Another question here, we have a 49-year-old female presenting to you with complaints of polydipsia, polyuria. She has been taking medications for depression, to which she associates to her recent constipation. So there is constipation, there is depression, there is polyuria and polydipsia. All 4 are pointing towards hypercalcemic condition, okay? Now look at her labs. Calcium levels are slightly high, 2.9 millimoles. Phosphate levels are little on the lower side, it starts from 0.8. Parathyroid, it says 5 picomole. 5 picomole is although within the normal limits, but the point here is it is detectable. So phosphate levels are detectable and CBC is normal and renal function tests are all normal, okay? So they're asking, what do you think is the most likely cause of the labs observed? So what is basically in the lab? In the lab, there is high calcium level, there is low phosphate level, there is detectable PTH, and everything else is fine. And the patient has symptoms of hypercalcemia. So I would now start thinking on the lines of the common causes of hypercalcemia. The first one is adenoma in the parathyroid gland, myeloma. Now if there was myeloma, number one, PTH levels will be depressed. We discussed that, okay? Number two, they're not giving you any hint in the question. They're not talking about any sign or symptom of myeloma. So I would keep that down my list of differential. Metastatic cancer, they have not described anything in the question like this. Patient with 49 years old, no other complaints. Metastatic cancer, not really likely. Drug induced, they have not given any drug so that we can infer hyperplasia in the parathyroid. Now, we are down to basically two options. Hyperplasia in parathyroid and adenoma in parathyroid. Now we have to go with the odds. We established this, that there is a patient with complaints of hypercalcemia. Labs are favoring hypercalcemia. So what's the most common cause of hypercalcemia? And that's adenoma. Okay? So we need to go by the common odds. And here it tells you that hyperparathyroidism can be of three types: primary, secondary, and tertiary. Primary is something when there is problem within the gland. Secondary when there is some other problem, and tertiary we'll discuss it. So primary hyperparathyroidism mostly is because of adenoma. You see? 80 to 85%. It can also be because of hyperplasia and malignancy in the parathyroid, but the most common is parathyroid adenoma. Now, if you go back to this question, it makes sense to you. So you have a patient with hypercalcemia, labs are indicating hypercalcemia, and we need to tell that what is the most common cause. It cannot be myeloma, metastatic cancer. Question is not telling anything about it. There's no drug to interpret. We are down to two options. Either it is adenoma or hyperplasia. Adenoma is the most common. We go with the adenoma, which is the most common answer, okay? Now, the rest should make sense to you because we discussed this all for hypercalcemia. So once you have done theories, physiology, and medicine related to hypercalcemia, you by default covered hyperparathyroidism, okay? Now see, what are the laboratory values in serum? What will happen? There will be high calcium, there will be high PTH because this is hyperparathyroidism. So when there is hyperparathyroidism, PTH level, primary hyperparathyroidism, PTH levels will be high. And because of high PTH, calcium levels will also be high. What will happen in the serum phosphate? Low. What will happen to serum alkaline phosphatase? High. Why? Because whenever there is some destructive activity within the bone, and constructive so bone metabolism, high alkaline phosphatase, okay? And you know there is bone involved, and what will happen to EKG? There will be short QT interval. Why there will be short QT interval? We discussed that in cardiology, but remember that is the common presenting laboratory values whenever there is hyperparathyroidism, okay? In urine, what will happen? There will be high phosphate. You know why? Because parathyroid stops reabsorption of phosphate. So more and more goes in the urine. What will happen to cyclic AMP? Increase. What will happen to hydroxyproline? Increase. Now one thing I want you to figure it out, it says high calcium in urine. High calcium in urine? Wait. We are talking about hyperparathyroidism. So when there is high parathyroid hormone, it goes to the distal convoluted tubule and increases the reabsorption of calcium. So in the urine, calcium should be low or high. Theoretically, you may think like this, that calcium will be low in the urine and more in the blood, but it doesn't really happen because there is a reabsorption saturation capacity. There is so much calcium in the blood because there is so much parathyroid hormone in the blood, more and more calcium is coming to the urine, to the nephron. It's trying to reabsorb it as much as it can, but there is a threshold after which it cannot reabsorb it. And that so much calcium finally spills into the urine. So in urine, despite high parathyroid activity, calcium of levels are usually high, okay? Try to make sense. And presentation, how would a patient with parathyroid adenoma will present to you? Same presenting complaints as that of hypercalcemia. because high parathyroid will lead to high calcium. Same complaints. What are the complaints? Fatigue, bone pain, fractures, polyuria, polydipsia, constipation, flank pain, all sort of things, okay? So you need to understand that the symptomology of hyperparathyroidism and symptomology of hypercalcemia are the same. Serum and urine lab values are the same. So this is life easy for you, okay? Makes life easy for you. Now, we also need to sometime before starting the management, we scan the patient, and when we are doing the scan, pre-op NAC scans help to locate exactly where the location of the parathyroid ball is, which means the adenoma, where is it? So scans help, and you also need to remember this condition, which is also identified on scans, osteitis fibrosa cystica. So what happens when there is high parathyroid? Osteoclasts are cutting the bone so much that within the bone cysts develop, you know, cavities develop. Why? Because the calcium and phosphates are gone. So cavities have developed. In those cavities, you know, inflammation happens, bleeding happens. So that combined picture is known as osteitis fibrosa cystica, okay? Causes severe pain to the patient. And if you have to do bone scans, DEXA is usually preferable over X-ray. So that's a key point that you need to remember. Another question. I love questions when they come to it, because as I said, in questions we have a chance to juggle our memory and try to figure out what is exactly happening. So let's read the question and try to answer it. You have received a referral. 45-year-old female patient with high calcium and parathyroid levels. Labs and initial workup suggest primary hyperparathyroid. So they have given you the diagnosis that the patient is suspected of primary hyperparathyroidism. Patient is also diabetic with good glycemic control. There is hyperglycemia, but now controlled diabetic patient. Which one of the following is a strong indication for planning parathyroidectomy? So basically, the question is telling you that there is a patient with hyperparathyroidism, so there will be hypercalcemia, and they are planning to do surgery. And which one of the following is a good indication to proceed for the surgery, okay? That you should do the surgery. Age of the patient, presence of diabetes, patient's gender, vitamin D deficiency, long-term presence of hypercalcemia. Now, of them, age. Here is the criteria. Why? Because here is the listed criteria if you see indications for surgery. Indications for surgery include, and this you have to remember because boards are big on this. They give you a case and they want you to decide if you want to do a medical treatment or you want to proceed for surgery. So in order to proceed for surgery, there should be bone involvement. You should have evidence that bone is being affected, like osteitis fibrosa cystica is there, okay? Renal involvement, you need to demonstrate that there is stone formation, for example, or nephrocalcinosis, for example. So if there is bone involvement, renal involvement, age is less than 50, and calcium is persistently high, how much high? 1 point high for several days, okay? So in the previous case, A was the best answer. Although you may think about option E, that there is long-term presence of hypercalcemia, they are not exactly telling you how much hypercalcemia. Is it exactly 1 point above? 1 point above? So usually in the examination, guys, this is what happens. They take you down. A good student, you know, a good student is finally down to usually 2 options. And both of the options are looking very close to each other, and the student is confused which one to pick for. This is where they you know, judge you that who is better student, right? So E could be a possibility, but exactly it has to be 1 point above the normal value for several times. And they're not telling you this, that how much above. It may be 2.7, it may be 2.8, but it has to be 3.8, you know, 3.6, 3.7. So the values are not given, therefore the best option is age of the patient, because the patient is less than 50 years of age. And if you now see the management plan, surgery is the standard of care for hyperparathyroidism. If surgery is not possible because of any reason, you give something which blocks parathyroid, which is cinacalcin, okay? Now, post-surgery, this is usually also asked in the examination quite a lot, that what is a hungry bone disease? A hungry bone disease is something which happens post-surgery because bone starts remineralizing very rapidly. So what happens that during hyperparathyroidism, bones are being cut off. So you are chopping off the bone so rapidly. once the surgeons remove the parathyroid, now the bones are not being chopped off. So they start remineralizing, they start depositing calcium and phosphate, okay? In this process, they do it so quickly, that the calcium levels go very down. So after surgery, there is sudden hypocalcemia because the bones are so hungry. This is why they call it hungry bone disease, okay? Now this is uncommon because usually pre-op they give alpha calcidol and vitamin D, and you have to monitor the labs for several days to make sure that calcium levels are not going down after surgery. I hope this slide is very clear, okay? So now that we have discussed a lot about hyperparathyroidism, which was primary in origin, which means that the problem was within the parathyroid gland. Now let us talk about two more conditions which are called secondary hyperparathyroidism and tertiary hyperparathyroidism. Now, in secondary hyperparathyroidism, there is low calcium because of some other cause, and one of the most common causes is chronic kidney disease. So if there is chronic kidney disease, calcium levels go down because vitamin D is not being activated and calcium handling doesn't happen properly. So calcium levels go down. Also because of high phosphate levels, it binds to calcium. So in kidney disease, chronic kidney disease, there is hypocalcemia, and hypocalcemia is a trigger for increased PTH. So this sort of hyperparathyroidism is secondary to low levels of calcium because of some other cause such as chronic kidney disease, okay? So remember this thing, and since because of kidney disease, it will be a lot of PTH. PTH will go on to bone and performs all its function. So this will cause a lot of bone pathology, which is secondary to actually the kidney pathology. Therefore, a term has been used for this, renal osteodystrophy. So renal because it has an original problem in kidney, osteodystrophy because the bone is now dystrophied because of high PTH levels, okay? And the labs will be, understand this, high PTH because it is hyperparathyroidism, but low calcium because that was the initiating trigger, okay? Now, this is very interesting, tertiary hyperparathyroidism. Now, sometimes what happens that initially because of chronic kidney disease, there was high parathyroid. Chronic kidney disease, low calcium and high parathyroid hormone. Sometimes because of long-standing hyperparathyroidism of this sort, parathyroid glands go autonomous and automatic, that they never come back even if you remove the the kidney problem. So there was chronic kidney disease, you remove it, treat it, but still parathyroid are not coming back to normal. So they persistently have very high numbers of PTH, parathyroid hormone. So if because of long standing secondary hyperparathyroidism, parathyroid levels don't come back even after removal of the initiating cause, this condition is known as tertiary hyperparathyroidism, okay? And one important point is to remember that in tertiary hyperparathyroidism, the PTH levels are very high. They are not marginally high, they are very high, okay? And therefore, the calcium levels are high, understandably, because PTH will go and act on the bone and increase the amount of calcium in the blood, also the phosphate. So these will be the lab values, very high PTH, high calcium and high phosphate, okay? And why does this happen? Because of long-standing secondary hyperparathyroidism. Now here is a question that we need to discuss. A 39-year-old woman presents to you in your clinic with a history of progressive CKD due to IgA nephropathy. PTH is very high, around twofold, 19.8 picomoles, and adjusted calcium is also high. Which one of the following do you think is the pathology? So what are the lab values? High calcium and high PTH. Now high calcium and high PTH also happen in primary hyperparathyroidism. It also happens in tertiary hyperparathyroidism, but it does not happen in any other of these. Men, we cannot predict. Option C is not the right option because they have not told any other glandular involvement. So we cannot talk about men. Pseudo hypoparathyroidism is something when there is high, when the PTH levels are normal or even high, but there is resistance in the end organ. But there is nothing mentioned like this in this scenario. And due to myeloma, they also do not talk anything about myeloma, okay? So they're not talking any indication or any symptomology about myeloma. So down to two options again. And those two options are option A, option E. I would go for option E because so there are two hints. Number one, there is long-standing chronic kidney disease. Okay, there is long-standing progressive chronic kidney disease. So this is one hint that because the kidney disease is so prolonged, the parathyroid goes autonomous. And the second hint is that the PTH levels are very, very high. So when the PTH levels are very, very high, it is also an indicative of tertiary hyperparathyroidism. Okay, so now this should make sense to you. There is another condition which is called familial hypocalciuric hypercalcemia. Now what happens in this disease is that the calcium sensing receptors which are present on chief cells, very good, which are present on chief cells, those are mutated and they are not able to sense. So for example, if there is normal calcium or even high calcium in the blood, they think there is low calcium. When there is low calcium in the blood, they think there is high calcium. And therefore, even in the presence of high calcium, they perceive it as low calcium. And whenever they think it's low calcium, they guide the chief cells to produce more and more PTH. And PTH goes on to kidney and reabsorbs calcium and goes to bone and tries to increase calcium content. So overall effect in the serum is increased calcium. And in the urine is decreased calcium because PTH is going to the kidney and reabsorbing a lot of calcium. So the overall effect is hypocalciuric in the urine, low calcium, but hypercalcemia in the blood, despite already hypercalcemia in the blood. So the point is, this is paradoxic. When I say paradoxic, it means in the condition of high calcium in the blood, parathormone levels should be low, but it doesn't happen. Even in the high calcium levels, parathyroid levels go high just because the sensing mechanism is faulted and it is perceiving the high calcium as low calcium. Okay, so see the description here, mutation in the calcium sensing receptors. Although the calcium level is high, but the calcium sensing receptor perceives them as low and paradoxically produces high PTH. Okay, and this is important that we usually do calcium and creatinine ratios in blood as well as in urine to establish if this is familial hypocalciuric hypercalcemia. Okay. Now a couple of slides about hypocalcemia. We have up till now we have been talking about hypercalcemia and hyperparathyroidism, which are far more common than hypocalcemia. Hypocalcemia is less common, but you need to understand that there are some symptoms associated with this and you need to know the management plan. Okay. So most common cause is chronic kidney disease. In chronic kidney disease, there are high serum phosphate levels, which binds to calcium, leads to hypocalcemia. That's the most common cause. Other causes include, think about it. If there is a condition where PTH levels are low parathyroid hormone, then the calcium levels will be low by default. Now, what are the conditions when PTH levels can be low? Say, for example, surgery. A surgeon was doing thyroid surgery and by mistake, parathyroids were also removed as a complication of the surgery. Or if somebody did parathyroid surgery. So if parathyroids are removed, no parathyroid hormone and hypocalcemia. What about DiGeorge syndrome, when there is embryological problems and parathyroid glands are not produced effectively? Again, low parathyroid hormone and hypocalcemia. So any condition where there is low PTH or low vitamin D, or if parathyroid is there, but it is not able to work because of mutations in the receptors which sense parathyroid hormone, okay? So, which is called pseudo-hypoparathyroidism. So, this diagram lists all the possible causes, potential causes of hypocalcemia, okay? Clinical features. Now, before I tell you, remember this one thing. When in hypercalcemia we were discussing clinical presentation, what were the presentation of hypercalcemia? Because there was a lot of calcium, the sodium channels were guarded and sodium was not able to enter into the channels to do the action potentials. Therefore, everything was delayed, was slowed. So low action potentials, fatigue, constipation, things like that, yeah? Here it's the opposite. There is low level of calcium, hypocalcemia, so the channels are unguarded. More and more sodium goes in, more and more sodium goes in, more and more action potentials, more and more action potentials. And because of more and more action potentials, there is irritability and excitability which is increased, okay? So this is what the patient presents to you like: neuromuscular irritability, neuropsychiatric manifestations, paresthesias, numbness, particularly about the lips area and fingers. Why? Because there are more action potentials, and before the previous action potential diminishes, there is new one, another one, to a point that the action potentials are no more going in the normal physiological fashion, and the patient does not feel anything. Okay, the nerve endings go just like in this condition, hyperexcitable condition. Cramps and tetany, increased muscular contraction. Also, if you simply tap the facial nerve, the facial muscles twitch. This is called Schwastic sign, and there is another sign which is called trouser sign, where you inflate the blood pressure cuff and the hands go like this. Okay, so these are two important signs very commonly given in the examination. What will be the laboratory picture? Do you remember the laboratory picture of hypercalcemia? So if hypercalcemia was there, the patient used to come to you with constipation, stones, bone pain, abdominal pain, lethargy. Then you order calcium levels. If calcium levels were high, you order PTH. If PTH was high, it is primary hyper. If PTH was low, it was due to some other tumor. Remember that? Now here, if there is a clinical presentation which suggests hypocalcemia, you order calcium levels and they are low. This is enough. This is enough to diagnose a hypocalcemic patient, okay? And then there are all the other tests, but not routinely done. So these tests are usually not the next best step in diagnosis of hypoparathyroidism. This is enough, okay? How do you manage? You give vitamin D, you give cholecalciferol, obviously. In very rare cases, if this is severe hypocalcemia, you may have to give IV or oral calcium supplements, but usually this is not required. One important thing to remember here is this: whenever you are treating a patient with hyper or hypocalcemia, you have to monitor calcium levels for a certain period of time, so that the patient should not switch from hypocalcemic state to a hypercalcemic state, right? A few minutes on calcitonin. Calcitonin is another hormone which is released from the parafollicular cells of thyroid. In the thyroid gland, there are follicles, and in between the follicles, there are parafollicular cells which release calcitonin. And the job is to oppose the action of parathyroid hormone. So whatever parathyroid does, it opposes it. Parathyroid increases calcium level, it decreases calcium level. Parathyroid decreases phosphate in the serum, it increases phosphate. So opposite functions, okay? But here is the good news for you. See this? It's not a major player in calcium metabolism, okay? So calcium regulation, PTH is the major player, parathyroid hormone. So if in examination you are supposed to get 2 or 3 questions from parathyroid, or maybe 1 question on calcium regulation, it will be from more important, more common things, okay? Calcitonin, not a major player. Last diagram, and then we are done with parathyroids. See this graph, on the x-axis are calcium levels, on the y-axis is the PTH levels, in the middle here is the normal condition, okay? Now, what happens if there is high calcium and high PTH? Now think in your head, high calcium, high PTH is primary hyperparathyroidism, which can be because of adenoma, which can be because of malignancy or hyperplasia. But whenever there is high PTH, high calcium, think of primary hyperparathyroidism, okay? On the contrary, if there is low calcium and high PTH, that is secondary hyper. Why? Because there is low calcium because of some other problem, kidney failure, and that low calcium will trigger PTH, okay? So that is secondary hyperparathyroidism. There's no fun in telling you that whenever there is high PTH, it is called hyperparathyroidism. High PTH, hyper. Now, if calcium is also high, primary. If calcium is low, secondary, okay? Now, there can be low calcium and low PTH. Low calcium and low PTH is usually primary hypoparathyroidism, which can be because of surgery or can be because of autoimmune problem. So PTH is low and calcium is low, okay? And then there is a condition when calcium is high but PTH is low. That is because of some other cancers such as myeloma. Remember the diagnostic grid for hypercalcemia? We discussed that if calcium is high, you do PTH. If PTH is high, primary hyperparathyroidism. If PTH is low, think about other tumors, okay? So this is the condition where PTH is low, but calcium is high, okay? This diagnostic algorithm is of great significance in solving your board's questions. If you understand this clearly, this means you have mastered the parathyroid glands, the objective of today's lecture. If you have any query in understanding this diagram, please rewind the video, watch it again. Unless you understand this picture completely, each and every word on this diagram should make sense to you, should be clear to you, okay? This is all for today. Thank you very much for watching the video, and if you have not subscribed the channel as yet, I request you to please subscribe the channel so that I continue making more and more videos for you. Thank you once again. Take care of yourself, and I will see you in next video very soon. Thanks a lot.